Let me know if you want to see the sagittal or the coronal view also.
We've gone through this earlier, Imran.
Yes, sir.
Everybody has to learn to see the axial images and reconstruct the other images in their mentally.
Yes, sir.
Reconstructed images can be very fallacious.
Correct.
Yeah, Shubham, we are waiting for you.
Yes, sir. Sir, so this is a contrast enhanced CT scan of the KUB, sir. In this, the right kidney appears to be normal with normal size, shape, and contour, with no any radiopaque density seen in the right kidney, and normal expression of the contrast can be seen. Sir, in the left kidney, sir, the size of the left.
Hold on. You cannot use terms loosely. Can you see the excretion of contrast here?
No, sir. No excretion.
What is the first thing you should ask for when you're given this CT?
The delayed film. So first we will ask for the non-contrast film, and
yeah. So you can't wait for me to tell you that.
Yes. So can we have the non-contrast film?
Manish?
Sir.
Manish? Hello, Manish?
Yes, sir. Yes, sir.
Just a question. These CT scans that you guys are showing, do you all have the software to download it, or does it come in a manner that can be downloaded easily for you? Because it's obviously done somewhere else.
It has to be compatible with our software, sir. I think it's DICOM only, or a variation of that.
Yeah, DICOM, sir.
Some of them just don't open enough, so even with the DICOM.
No, but I tried to download it and send it across by email, sir, but it was not possible. I made a short video clips and sent it to the other students yesterday, sir.
Okay.
Sir, it is a non-contrast axial scan of CT KUB. The left kidney is normal size and shape, and there is no any radio.
Right,
Hello, sir.
Left or right? You said left kidney is normal in shape.
Sorry, right kidney. The right kidney is normal size and shape with no any radio dense opacity seen in the right kidney.
The size of the right kidney is normal?
Right kidney looks little bigger than size is little big, sir, as compared to.
Is that an important consideration? You're looking at.
Yes.
Very important. Look at, people don't comment on the sizes these days simply because you got the CT images and you just cursorily go across them.
Yes.
It would be larger on one side.
The right kidney looks larger.
It's going all the close.
Sir, the left kidney, sir, it is smaller in size. Sir, smaller in size. Reniform shape is maintained, sir, but the looks contracted. And sir, there are multiple radio dense opacity which is seen in the pelvis also, and also in the interpolar region of the left kidney. And sir, in the left kidney also some uh, some calyceal, no sir, parenchymal thickness also appears to be a little less in case of left kidney, sir. And sir, further comment.
Less or significantly less? So when you said that the kidney is smaller on one side,
Yes, sir.
you must be very definite about the term that you use. You can't say slightly less than, not very sure.
Or smaller in size, sir.
Show the other films. Just go. You showed some
Contrast images.
No. Same. AUB. Plain CT. Just see.
Pelvis, sir, dilated with a radiodense opacity seen in the pelvis, sir.
Anything else on the left kidney that you notice? When you see abnormalities of this nature, the kidney is smaller in size, certain pathological features will be present in that kidney, and those pathological features might reflect on a CT scan, which is able to show us tissue differentiation. You understand my question, or is it too complicated? The idea is to know what the consequences of this sort of radio densities in the kidney will result in. And that can manifest as certain things in the kidney. For example, if you look at this kidney, you must say whether there is any evidence of perinephric standing.
In this film,
any uneven texture of the cortex.
In this film, we
CT scan. I mean, you can see it quite nicely. Lots of things.
Yes, sir, but in this film we can't see the perinephric standing.
See the film.
Yeah, sir. Shubham, negative findings which are important have to be specified. And Shubham, suppose I said that in this cut I can see scars. Would you agree with me?
A little difficult to comment, sir.
No, I would say that there are no scars which are visible in this cut. But if you look at the other images, there is an extension. There is a point at which there is hardly any parenchyma. Assuming this is a stone, so between the stone and the parenchyma, there is, between the stone and the edge.
Hello?
Yeah. I think NU has gone off. Continuing on what Dr. Manish, can you hear me?
Yes, sir. Yes, sir.
Continuing on what Dr. Manish was saying, in the term pyelonephritis,
yes, sir,
both is a clinical entity, is a pathological entity, and is also a radiological entity.
Yes, sir.
Especially we're talking of chronic pyelonephritis.
Yes, sir.
If chronic pyelonephritis is a clinical entity, then the patient is likely to present with recurrent episodes of urinary tract infection.
Yes, sir.
Which are located in the upper tract.
Yes, sir.
All right?
Yes, sir.
If it is a pathological specimen, then the classical feature is thyroidization of the collecting tubule, just like what you see in the thyroid gland.
Yes, sir.
And there'll be tubular atrophy, there'll be some preservation of glomeruli, there'll be periglomerular sclerosis. Okay? But more of tubular dysfunction in chronic pyelonephritis.
Yes.
If you are looking at it from the radiologist's point of view, then chronic pyelonephritis has to have a scar.
Yes, sir.
And that scar will be opposite an area of the collecting system. All right?
Okay.
Why is that? And that is because of the anatomy related to the collecting tubules, the ducts and the papilla, etc. So scarring usually in radiological terms is an area of depression or alteration in the renal silhouette with an associated abnormality or in the overlying or underlying calyx.
Yes.
So you look at these films and you see, go down. I don't think we can yet.
Yes.
Can you scroll? Any, are you back? You look at this.
Yes, sir.
This particular thing, huh?
Yes, sir. In this cut, you can see the perinephric stranding is there, and also
Calcification, huh?
yes, sir.
Does this look anything like a stone?
No, sir.
It's a very bizarre shape, isn't it?
Yes, yes,
It's a very bizarre shape. And you see at that point, there is hardly any cortex.
yes, sir.
Huh? In fact, some of these areas of calcification are actually seem to be outside of on the surface of the kidney.
Yes, sir. Yes,
And some other cuts.
yes, sir.
Huh?
Yes.
And there is no doubt that there is what appears to be a stone in the pelvis, in the upper ureter.
Yes, yes, sir.
But this is a very bizarre area of calcification.
Yes. So this can be, sir, scarring process, sir.
Sorry?
There's a scarring process going on in the left kidney, sir.
Not going on, has already occurred.
Yes.
Okay.
Sir, contrast images we can go.
No, hold it. Just go back. Go scroll frame by frame. Okay, now look at this now.
Yes.
Look at this and comment on this.
Sir, in the left kidney, sir, is small and contracted with sir, there is a radio dense lesion in the interpolar region of the left kidney with surrounding hypodense low attenuated lesion. And apart from this, there are also other hypoattenuated lesion which can be seen in near the upper pole of the left kidney.
Okay, go to the next frame. Just the next frame. Okay. Right. Stay there now.
Sir, in this cut, we can see, sir, there is irregular shape of radiodense opacity, and around this radiodense opacity, there are hypodense lesion involving the interpolar and the upper polar region of the left kidney, and sir, some in the perinephric, and this hypodense region seems to be involving the perinephric region also, extending towards the perinephric region also, and perinephric standing can be visualized, and this irregular shaped radiodense opacity could be due to some the pooling of contrast in this area, sir.
So you think this kidney, that white stuff is pooling of contrast?
Could be, sir.
You think that white stuff is pooling of contrast?
Or the calcification, either of them.
No, you saw it in the plain X-ray.
But in the plain X-ray, sir, this was not. It is increased, sir, from the plain X-ray, plain AKUV, which were saying that there was not so much, but in this increased radiodense opacity, sir.
So you're saying the shape of this calcification was different here and it is different in the plain X-ray?
Yes, sir.
You sure?
It has increased, sir. in the plane it was not so much, sir, but in the contrast images there is increase in the radiodense opacity. So it could be along with calcification, some pooling, sir, both together, sir.
So, Shubham, this is not a test of memory. You would be well within your rights to say that I want to see the plane again. Okay?
Okay.
I know that last time Dr. Mohan had said that
Yes.
the radio density has increased, but
Yes.
you can always go back to the plane image, which is what you would normally do. So if you want to go back and compare. Now, last time we had said that if it has increased, it could be AV malformations.
Yes.
Let us, for discussion's sake, say that it has not increased.
This is a plain X-ray.
Yes, sir.
Well, look at it this way. If that radio density has increased in the plane, has increased in the contrast film,
Yes, sir.
then we are suggesting that there is function in that area, isn't it?
Good morning, sir.
Yes, sir.
Fine. They indicate that there is function in that.
Yes, sir.
Okay. But look at the state of this kidney and look at the rest of the kidney.
It's small in contrast.
Already seeing excretion, if you are saying excretion, you are seeing excretion in a lousy part of this kidney when you are still in the nephrographic corticomedullary phase of the CT scan. How is that possible?
Shubham, we discussed this. Answer that question.
So it's mostly calcification, sir. Since it's a corticomedullary phase, we cannot comment on the reason of contrast. So it's
So you look at the opposite kidney also. Look at the opposite kidney, which is a functioning good kidney.
yes, it's in corticomedullary
The
phase.
phase of that and see in this, what is that? That is still not yet showing you the PCS. It's still in that early phase. Huh?
Yes,
Yeah.
No, Shubham, I have an objection.
yes,
We
sir.
discussed last time, if you see contrast in the parenchyma at this phase, what does it mean?
So it is due to AV malformation, sir, and also some this contrast in parenchyma in this phase. We can also say that due to some any growth which is enhancing on contrast.
No, we discussed that this could be an AV malformation where there is quick appearance of the venous phase. And if you can see the renal vein in the arterial phase, that is another evidence that you have a possible AV malformation.
Yes, sir.
But for today's discussion, let us say that there is no increase.
Okay. So this is
What is that white structure which is coming out from the hilum there? There is one white structure, no, in this next one.
yes, sir.
What is that white structure coming out?
So it could be either renal vein or artery.
In vein?
That is outside
In the aorta. It's the aorta. You think it's a renal vein, that thing?
We will
the artery.
We continue showing the region of that vein.
The same patient we had seen.
renal artery, sir.
When you see something like that coming into the hilum, and it's in this phase of the CT, it has to be either the main artery or a branch of the artery.
Yes, sir.
If it is the main renal artery, then if you look at that, you are worried. It is looking like one scraggly little piece of string there. It looks very thin. that gives you an indication as to the state of function of the kidney. We don't look at all these parameters, but a good kidney will have a good renal artery. A poorly functioning kidney will have a very poor quality renal artery. Your nephrectomies for small kidneys and all, those arteries are so tiny, nothing at all.
Yes.
So look at it, compare it.
So the caliber of the left renal artery is less as compared to the right side.
You have to comment on many factors. No? All these parameters will give you ideas as to what is the state of function of this kidney, what is happening here. Now it appears as though there is another hypodense lesion sitting in the hilar area.
There is a pelvis, the extrarenal pelvis.
See all the films. There are numerous things in this section CT that warrants discussion. It's a very interesting CT scan.
In this cut, we can see the same multiple hypodense lesions, along with the pelvis is extrarenal and dilated, and the renal artery caliber of the left side is less as compared to the right side, and perinephric stranding can be seen, sir, in the interpolar region of the left kidney, along with reduced parenchymal thickness, sir.
Show some more cuts.
So Shubham,
Yes, sir.
one of the things that was very evident in that artery is what you would report on a DDPA perfusion scan. Right? This looks like a underperfused.
Yes, sir.
The renal artery contrast density is less than that of the aorta.
Yes, sir.
What is the other striking feature here in this kidney on the left side? You are seeing that dilated pelvis.
Yes.
And you are seeing a dilated, has to be another hypodense dilatation which is per ureter. If there is so much of dilatation of the pelvis, does it make you wonder as to why there is no dilatation of the PCS?
Sir, there is no dilatation in PCS because...
No, that's what I'm pointing out to you. If the pelvis is so dilated, the PCS is not dilated. Is that strange? Does it warrant some other thought processes in your mind? See the films. As I said, this is a very good CT scan for discussion. There's lots of things on this. Keep going to the later phases of this CT.
This is the venous phase. have delayed phase.
Okay. Whatever it is, there is a significant dilatation of the renal pelvis,
Yes, sir.
isn't it?
Yes, sir.
As well as what else is there in that pelvis?
The pelvis, there is no contrast. There is there is not enhancing. The pelvis is not enhancing.
Apart from no contrast.
Sir,
Compare this.
Compare this to that. What is that white line around the pelvis? Huh? Is there thickening of the pelvis?
yes, sir.
Huh?
Yes.
No, these are factors, these are points that will help you try to arrive at a diagnosis in such a patient. You've got a dilated pelvis, you may argue and say that, oh, this could be an extrarenal pelvis. But an extrarenal pelvis should have no business to be having a thickening of its wall. You have a dilated pelvis and the PCS is not dilated. And this kidney is poorly excreting at this point. So you go down and look at the rest of the ureter and see whether the same phenomenon occurs there. And you can see that white stuff slowly withering away. And after that, you'll have to imagine that it exists.
Yes.
So before saying and assuming that it's a dilated extrarenal pelvis, you should have told us about the status of the ureter. Can you comment on this?
Sir, ureter is ureter is sir.
Can you see the right ureter?
No, sir.
Can you see the left ureter?
Yes, sir. Yes.
Yeah, so is it equal? Does it appear dilated?
So it appears dilated and
And you can follow it down for one or two vertebral levels, and then it starts seeing.
yes. Ureter appears dilated, sir, and
So what is?
Remember one more thing, that the ureter is a very flimsy structure and it is easily or better identified when there is contrast within it. If there is no contrast and if the ureter is seen on the plain film and it's got all these features, then maybe there is pathology. That's why you're seeing it. It's the pathology in that ureter which highlights it on the CT scan rather than actually the contrast in the ureter. You understand what I'm saying?
yes, sir.
All right.
So if we have this sort of a small contracted kidney with no pelvic dilatation, equal pelvis and upper ureteric dilatation, does it help you make a diagnosis?
Sir, any obstructive pathologies are in the distal ureter, which is causing back pressure changes and dilatation of ureter. And
So I asked you, where is the back pressure change in the kidney? If
Sir,
the pelvis is so dilated, why is there no hydronephrosis in that kidney?
because it is due to chronic repeated infection. This kidney has undergone chronic pyelonephritis changes, so there is no dilatation in the kidney. But
Shubham, which type of chronic pyelonephritis can present with all these features? contracted kidney, parenchymal calcification, no dilatation of pelvises, thick-walled pelvis, thick-walled upper ureter with poor function.
Is it an inflammatory condition or is it a malignancy?
Or a stone disease.
What, Shubham?
Yes, sir.
बोला यार कुछ
It's mostly inflammatory conditions.
inflammatory lesion, right?
Yes.
Can you make a bet on one inflammatory condition?
Sir, tuberculosis also, GUTB, we can see this.
So why is that so difficult to come to?
So this patient had undergone ESWL 5 years ago. For presumably, let us say, the same stone, what you see presently. What is your comment on that?
Sir, please repeat, sir.
Would you give, suppose I say this is a stone, would you give lithotripsy? This is not tuberculosis, this is a stone.
Sir,
Today, would you give lithotripsy or are there contraindications to lithotripsy?
sir, it's not a contraindication, sir, because we should always give a chance if there is a stone.
Answer that question very carefully, Shubham. You said it's not a contraindication. Before that, Prabhu, I think, asked a question which Manish modified, hoping that you might answer it correctly. This patient had ESWL 5 years ago, was a statement made.
Okay.
All right?
Yes, sir.
Immediately when a question like that is asked, you have to think in your mind, why is this guy asking me that question? How did they give ESWL to this sort of a lesion?
Sir, due to
The reason I'll tell you is that they probably did not do a functional study of that kidney before ESWL. That is my reading. One of the tenets of ESWL is that you must have a functioning kidney. And this is where mistakes are made in ESWL, where people have knocked off aneurysms of the renal artery, calcification. It's common. You see anything, bang it. KUB, ultrasound, bang it. So this is what would have happened, is my guess. That they would have given ESWL to this patient 5 years ago based on a single X-ray without any functional assessment. And to say that you, and then the next line to say that you think, yes, ESWL is a good idea, it's a very bad idea. You understand how the question has been asked and how you have to think about it?
yes, sir.
Yeah. Because constant mistakes we make. I don't know if ESW was given, but you know, the question was asked very deliberately.
So first we will do the functional study, then after that we will decide whether to go for.
Could this be stone in calyceal diverticulum? And that's why they gave ESWL.
Could be, sir.
It doesn't look like a calyceal diverticulum at all. In a calyceal diverticulum, what kind of stones do you get? You have to go find out. So what is the other reason why you should not give lithotripsy to this if it is a stone?
Sir, it's already a contracted kidney and
You agree, that is one reason. Is there any other reason which is, I have shown you this cut?
Sir, this radiopathy doesn't seem to be a stone. So
If it is a stone, one contraindication is poorly functioning kidney. Any other contraindication? Can you quickly do a test at this point and what am I doing?
Sir, the Hounsfield unit is very less, sir. So lithotripsy will not be able to break the stone. It could be a matrix.
Are you sure? We have very loud protests in this room. I agree with you that if you have a matrix stone, it will not break. But otherwise, if the Hounsfield unit is more than 1,000, it will not break. But does this look like a less than 2 centimeter stone to you?
No, sir.
Yeah. So you have to look at all that. Tell me any other contraindications in any patient that you know of to lithotripsy. In general, what are the contraindications for ESW?
It is coagulopathy and urinary tract infection and some
Active urinary tract infection. Don't say just urinary tract infection. It has to be active. Active UTI.
It's an active UTI and any anatomical abnormalities which may obstruct the passage of residual fragments.
So the correct term to use is distal obstruction.
Distal obstruction.
Any other absolute contraindication?
And pregnancy, sir.
What about single kidney? Is that a contraindication to ESWL?
No, sir. If there is no any distal obstruction, then we can go for ESWL in single function.
Patient will come back in acute sepsis, acute renal failure as soon as 2 fragments go into the urine. So I will say it is anuria. So I will say it is a contraindication. So how will you counter me?
Sir, post ESWL, we will firstly confirm that.
What will you do pre-ESWL?
Single kidney is a relative contraindication. In the earlier books, it used to be an absolute contraindication. Then people questioned and said why. And then we said no, it's not an absolute, it's a relative. If you can obviate the complications of Steinstrasse, infection and obstruction and anuria.
Yes.
Isn't it?
Yes.
Yeah. So what does that entail you to do?
How will you obviate those complications?
We will ensure that all the residual fragments have been removed, sir.
You are a urologist. What do you do every 8? Will you start alpha blocker?
Yes, sir. We will give alpha.
I think everybody is having fun at your expense. We apologize for that. But you will stent this patient. What is so difficult about that? Not this particular patient. But if there is a solitary kidney, you want to give lithotripsy with a stent inside.
Yes.
Shubham, I'll give you another clue. I'll give you another hint. You might take it as a hint or a piece of advice. Just because somebody tells you, will you do this? Don't keep following that and say, yes, I will do it. He could be leading you up the garden path. You know?
Yes.
So, you get a statement right now and you... So please be careful.
Yes.
Okay, so let's come back to this patient. This is for everybody. Lithotripsy is very important and we can go on and on lithotripsy. So please read those chapters, whoever is not ready. Even if you're not giving lithotripsy, it's an important modality. It is still being given and it is treating stone successfully. So all of you should know. So coming back to this case, Shubham, now what do we want?
I will want a functional study of this patient to see what is the function.
You have a contrast CT, no? What do you want?
Still, sir, we cannot see the contrast excretion, but some contrast uptake is there in the left kidney. So we will want to know the differential renal function and also the exact function of the left kidney.
You be specific. No, I don't understand that long stories.
Sir, I will go for DMSA, sir, of this patient.
Why won't you go for DTPA?
Sir, because in one cut we were seeing the scarring process and it's mostly in the cortical region. So we will go for that study that will more give a idea for the cortical, so the DMSA is localized in the cortex.
Any other reason why you wouldn't go for a DTPA here?
Sir, because the DTPA is based on the glomerular filtration, and since the left kidney seems to be less functioning, so the exact idea we cannot comment around DTPA.
What is the other facet of a DTPA which is useful?
DTPA, sir, it can be done in other like renovascular hypertension. Also, we can do the DTPA.
No. Apart from knowing the GFR of a kidney, what is the other component in a DTPA scan that is useful to urologists?
In the DTPA, sir, we can also comment on the perfusion. We can see, sir, and apart from function, we can see the perfusion of the...
Is there a renogram attached to a DTPA?
Yes, sir.
So what is that renogram?
Captopril renography.
Captopril renogram chala gaya yaar. Standard renogram. What is the advantage of a standard renogram? What does it tell you?
So it tells the perfusion and function of the kidney.
It tells you whether there is a possibility of obstruction, isn't it, to the drainage system. You see that curve, isn't it?
Yes, sir.
All these curves, type 1, 2, 3, 4, type 3A, 3B, all that is there. Huh?
Yes.
So when you already know that the kidney is obstructed from the CT scan, you got a dilated pelvis, we have discussed that this ureter is hopelessly scarred and you're not looking for obstruction, isn't it?
Yes.
So when there is a clear-cut evidence that there is obstruction, there is no point in doing that DTPA unless you have doubtful obstruction, in which case you might do some other test. So you want to look at cortical function and therefore a DMSA may be useful in this situation.
Yes.
It's not for looking at a scar because already the CT scan is showing you many things.
Yes.
But what Dr. Prabhu was asking, why do you need all this? Isn't this CT scan enough to tell you this kidney is small in size?
Sir, since on CT scan also we can see that small inside and poorly functioning, but we have to document the functions so that we can proceed further for the management. So we need to do some DMSA for the cortical functions, and also to see the scarring process we can only be visible on the DMSA. So we need to have a DMSA for this.
So tell us what you'll do for this patient. Cut a long story short.
Sir, on the DMSA, sir, the left kidney function is only 10%, and sir, it's very less non-salvageable kidney. So we will go for nephrectomy, left side nephrectomy of this patient.
Will you do anything else before you plan nephrectomy on this patient?
We will treat the first the infection part, sir, because the culture was positive, and control the blood pressure also because it is hypertension.
What else will you do? Before you turn him round or put the lap ports or whatever else you want to do to take this kidney out? Will you do anything else? Are you not interested in looking at that ureter, which is looking so suspicious? Wouldn't you like to do a retrograde at least on that left side?
Yes, sir.
Yeah.
Yes, sir.
You can argue and tell me anyway, I'm going to take out the kidney, of what use is a retrograde? It is knowledge, man. Huh? You want to know why that ureter is looking like that? It might alter the biology. Why should a ureter be scarred and thickened and narrowed if somebody has just had a stone disease like this, which is looking bizarre, on which maybe somebody gave VSWL and the kidney was poorly functioning?
So we will do a RGP, sir, before doing that.
Think so?
Shubham, this patient, he will tell that I want to see, I want the kidney, please don't remove the kidney. So what will you tell him to substantiate you?
I can't get you, sir, what you want.
Just to repeat that question.
Function is still there. He will tell that EMS still shows 10% function. I don't want to get the kidney removed. So please remove the stones and leave the kidney alone.
It's a poorly functioning kidney, so the salvageability is very less, sir. So we cannot salvage the kidney. So we will go for nephrectomy only, sir.
Why not put a stent and see?
Sir, there is no any obstruction, so there no obstruction can be seen. So the stent will not help in draining anything, sir.
So going back to the original finding on the CT, did the opposite kidney appear enlarged?
Yes, sir.
Why is it enlarged?
So compensatory hypertrophy, sir, because the left kidney is not functioning. So it's a compensatory hypertrophy of the right kidney.
If you do a retrograde pyelonephritis, what would you expect?
If you do a retrograde pyelogram, sir,
would you expect a normal ureter or would you expect a scarred and diseased ureter?
The scarred and diseased ureter.
If you had to reconstruct that ureter, what would you use?
So it depends on the length of segment of the scarred ureter, sir.
Whole ureter, I expect, will be scarred and diseased, because beyond the certain length, you can't see it because the rest of it is thick wall. Upper ureter is thick wall. So let's assume the whole of the ureter is going to be diseased. That is what I would expect. How would I replace that?
So your voice is little not audible.
How would I replace a diseased long segment ureter?
Yes, sir. So for a diseased long segment ureter, we can go for body flap, sir. And if that also not possible, then we will have to do auto transplantation.
Okay. Anything else? Any other options?
And renal descent, if possible, we can.
Can you leave the kidney alone and do something only to the ureter?
That is transureterostomy, if it's possible.
If you're thinking tuberculosis, we discussed last time this is a contraindication for transureterostomy. Stone also, if you're thinking, both are contraindicated.
Yes.
So what would you do? To replace a ureter, what do you normally use? Then?
Ileal ureter.
Yeah. So with this kidney, one, if you're thinking of tuberculosis, you don't expect the bladder to be available for body plan. Second, with such a long thing, I don't think you will be able to construct a body plan. Third, with a diseased ureter, with a diseased kidney, if you replace with ileal, what will happen?
The anastomotic leakage. There could be anastomotic leakage, sir.
No leakage. Perfect. What happens to a normal kidney pathology after you put up an ileal segment? Is there pyelonephritis in a normal kidney?
There could be, sir, pyelonephritis, sir.
Yeah. So now that we've given you some directions, can you answer Vinod's question? Why would you not reconstruct this?
Sir, we will not reconstruct because we are already seeing that the ureter is dilated and not good leaking, and also the kidney function is poor. So we cannot reconstruct because the kidney is already poor functioning. So
okay, but if you do RGP and you find that the ureter is absolutely normal, there is no problem with the ureter. The stones are there and the poor functioning. So then what will you tell? He will tell just to remove the stones and they will leave the kidney out. So for that, you have to think whether PCNL in this kidney in such amount of stones, such kind of stones, is it easy or it's going to be difficult?
Shubham, are you there?
yes, sir.
Okay. So even one is a technical difficulty, and even if you take out all these are stones, if you take them out, the kidney is eventually going to contract even further, and you're not going to gain anything. So what I would tell the patient is, even today you have a single kidney which is working, and this kidney has only caused infection. There is a possibility that once we subject it to biopsy, we might find something like tuberculosis. So you are best treated by nephrectomy. This is how you would probably speak to a patient, and this is how you should be answering Vinod's question.
Okay.
Just one point here before you close shop. If you look at this stone, the so-called bizarre area of calcium. Hello?
Yes, sir.
If
Yes,
you
sir.
look at this bizarre area of calcification, I would call it, it is surrounded by a hypodense area.
Yes, sir.
Okay, you mentioned that.
Yes, sir.
This is, when you see, this doesn't look like a stone. It doesn't look like a standard stone what you're seeing on this particular frame. It looks as though somebody may have given ESWL and fragmented. Even then, it doesn't look like, it's not very bizarre. So whenever there's bizarre calcification, you think of pathology. You think of dystrophic calcification and not standard metabolic calcification. All right? And that is what is worrying him. And if it is a hypodense area with a cyst inside it, with calcification, other differential diagnosis should pop into mind, considering the fact that this patient, forget the fact that he's had ESWL and all the rest of it. All right? There could be tumor also in a situation like this. All right?
Yes.
Number two, if you do PCNL into this, there could be a nephrocutaneous fistula.
Yes, sir.
This may be a blocked infundibulum and therefore is blown out and there's collection inside. But then this is clearly outside of the purview of the cortical surface of the kidney. It's well outside. So for all practical purposes, there is some serious pathology going on in this kidney unless it was all stone and unless we have earlier x-rays. Prima facie, on the basis of this x-ray, I would take this kidney out. Was the RGP normal in this patient?
RGP was not done.
RGP was normal.
Not done.
Not done.
Okay. So the radiologist has not given a significant so any idea what was actually, see, I used the word dilated tubules and thyroidization of tubules. Remember I told you this?
Yes, yes.
When the line was off, the features of chronic pyelonephritis, the clinical features, pathological features, radiological features, all three. All right?
Yes.
So what was the story exactly on this patient, Manish? He had ESWL or not?
He had ESWL, sir.
5 years ago.
Yes, sir.
Right.
At present, it was just active infection which he came with, and we got an effect.
What I want you to understand is, you look at the size of the kidney that was measured on the CT scan. If you go back on the report of the CT scan, you see the size. They said 9 centimeters. Go back on the CT image. Sorry to cut you short. 9 centimeters left kidney. Huh? And look at the pathological size. 7 centimeters. Go back to the pathology. Measurement 7.5 centimeters. Which is more accurate, the CT or this measurement size? You see? Why is the kidney looking bigger on the CT and smaller on the gross? Shubham?
Yes, sir.
Why is the kidney looking bigger on the CT scan report and smaller in the gross specimen?
Sir, there might be during operation and then
You think these fellows have chopped up the kidney or something? They've done a decent job, man.
no, sir, due to ongoing infection, sir,
CT scan said that it's a 9 centimeter kidney before surgery. When they took this kidney out and measured it, it was 7.5 centimeters. 2 centimeters difference, 2.5 centimeters difference. Huge. Why is there that increased size on a CT scan?
because the vasculature was intact that time, sir. So
That is the important thing. We tend to forget that when the kidney has got its blood supply on a CT scan, it appears to be larger in size. So you don't get carried away just by looking at that image. Look at the entire kidney and see whether this has got something. A 9 centimeter kidney has no business to have compensatory hypertrophy on the other side.
yes.
Huh? So, you have to add up all these features and then try to come to a conclusion and make a decision as to what you want to do for such a patient. Okay?
Yes. And sir, should we do duplex ultrasonography in this patient also, sir? Because ESWL with hypertension can be suspected renovascular hypertension also in this patient.
So what, you want to reconstruct the renal artery?
No, sir, but
Then what you want to do all that? You saw the renal artery on the
Yes.
CT scan.
yes.
There is no stenosis. I told you, look at the size of the renal artery. In a small kidney artery is small. You don't need huge blood flow in a patient who has got a small kidney. That's all. It's done. What are the classical features of chronic pyelonephritis versus hypoplastic kidney? Both of them, the kidney is small, the artery is small, but in chronic pyelonephritis, the kidney is scarred and small, whereas in hypoplastic kidney, the kidney is not scarred but still small, but the artery size remains the same.
Okay.
You got it?
Yes.
You see the artery, there is no stenosis here.
Yes.
So there is no point in doing all these fancy tests.
Okay.
Kidney got what it deserved, finally. Right.
Sir, are you traveling next Thursday?